actually, most of the articles in here are fairly straightforward stuff having to do with a few of the little aspects of acute management of some of the problems with diabetes. And there are so many acute things as well as chronic that obviously we're just doing a little hodgepodge. I think this topic is a little more interesting if we were to step back and look at a little bit of big picture stuff. And so maybe we'll run through this and then we'll talk about a little bit of the big picture stuff, because I think it's also important and we need to know about it even though we don't deal with chronic diabetes nearly as much as we do acute. So the acute issues, of course, are hypoglycemia, hyperglycemia, and the types of acute problems that diabetics get that nobody else gets, or that other people get but diabetics get more of. So things like vascular disease, infection, neurologic complications, etc. And, you know, we deal with those all the time. This chapter has a few little articles about a couple of these, and let's just run through them. And then maybe we can step back and talk a little bit about what is the real, what are the real issues with diabetes and what can we do to, what do we know that's useful for patients. So the first article is simply says that it doesn't matter where you draw the sugar from. Okay, not terribly important. I guess more important is, does the exact sugar matter? So a lot of papers will say, well, it was the difference between if you drew it from here, a finger stick versus a capillary is X. Well, what is the amount of difference that matters? Why do we care? Do we? So let's just ask, imagine somebody comes in, they're hyperglycemic. Does it matter if their sugar is 400 or 800? So what does it depend on? Okay, so one thing is might have nothing to do with sugars. Are they acidemic? We can get back to that in a minute. But what about the sugar itself? Well, so you're suggesting it might change your insulin dose. Should it change your insulin dose? What is a good initial insulin dose for DKA? What's the treatment of DKA? Fluids, okay? And in fact, insulin should be down the line a little bit. The worst thing you can do in DKA, I guess there are two things you can do that are really bad. One is not treat the patient, not give them fluids. And the other is to get them to correct the acidemia too quick. Because if you do that, you drive K into cells, they're already hypokalemic, you can kill the patient. I've seen that happen. So the easiest way to do that is with bicarb, for example, but you could also do that by just giving a lot of insulin or giving too much insulin. So you got to be careful about K when you're treating DKA. And the first thing is, of course, to treat fluids, and the second thing is you can touch a little insulin. The third thing, probably really second, is find out the cause of the DKA. But it probably doesn't matter whether it's 500 or 700. Yeah, there is non-ketotic hyperosmolar coma, which has something to do with hyperosmolality, which has everything to do with hyperosmolality. Some of that has to do with the sugar, but it doesn't matter what the number is. You see the patient. The patient's got that. You gotta give them volume. But how much volume you give them is patient dependent. It's not number dependent. So I don't think in high blood sugar it really matters. We know you can have really bad DKA and have a sugar of 300. So it isn't just the sugar high doesn't matter. How about low? When can you get hypoglycemic? When can you get symptomatically hypoglycemic? What number do you need to have? Low. Some people can be hypoglycemic at 60 or 70. Some people will be walking around okay at 30. So I don't think the exact number matters. So these papers that argue about which is the exact number, to me, is a little silly. How about and by the way, who remembers, when I started, the treatment of DKA, the amount of insulin was 100 sub-Q and 100 IV. 100, that was in Harrison's textbook of medicine. 100 sub-Q and 100 IV. How come we didn't kill all the patients? Because you only have a few insulin receptors. So most of it was just like pissing it away. Otherwise, we would have. because you don't need that. What do you need? You need a little tiny bit. 5, 10, who knows, whatever it is. You don't need a lot. You need to monitor the patient's response. And again, it isn't even the treatment. The treatment is water. So what about the pH? Does it matter if it's 7.1 or 7.05? When I started, you didn't give bicarb unless the pH was less than 7.2. And then it was unless it was less than 7.1, less than 7, less than 6.8. And now it's bicarb doesn't work. Don't give it. Causes harm. Give them water. So I don't think it matters so much what the pH is, and that's why a lot of these articles are not terribly important. What are the, let's just go run through some of the articles. 2 through 4 say, after you treat hypoglycemia in the field, is it okay to let the patient sign out AMA and not get further treatment? Is that dangerous? What do you think? Well, you're shaking your head. Yes, which?
It's dangerous if they're on oral hypoglycemia.
Great. So it really depends on which they have, okay? So these 3 articles say, no, it's not dangerous. And they say it's not dangerous because they had all these patients, they saw them, the patients refused, and nothing bad happened. Unfortunately, if you read these articles, nothing bad happened to the patients we know what happened to. In one of the studies, 40%, they couldn't find them. They were all buried. I mean, no, I'm making that up, but if they can't find them, maybe it's because they had a bad outcome. So on the one hand, of course, most hypoglycemic episodes don't need a hospital. The overwhelming number of hypoglycemic episodes, the true denominator, is not measured in these studies. What happens to most hypoglycemia? The patient takes some sugar and goes about their business. Hypoglycemia happens all the time. The vast majority never sees a healthcare provider at all. So on the one hand, of course, overwhelmingly, it's no big deal. It's sort of like a seizure. How many of you had a patient who comes in after their seizure, they have their usual seizure, and they want to go home? And the only reason that they're there is because they happen to have their seizure in front of strangers. If they had it in front of their family, they would have their seizure and that would be it. They have chronic seizures. Every 2 months they have a seizure. It's no big deal. They don't need a big workup. The only reason if they're awake and normal, and this is just part of their seizure pattern, in the same way with hypoglycemia. But always remember that there is a subgroup who are hypoglycemic from a long-acting agent. So when it's hypoglycemia from insulin, that's easy. It's a no-brainer. When it's hypoglycemia from an oral agent, particularly a sulfonylurea, they can crash again. Now, of course, if you ask, do you let them go AMA? If they're competent, they have the right to do that. But I'd advise somebody with an oral agent, you really don't want to do that because you're going to have recurrent hypoglycemia.
Is there a requirement to report them to the DMV?
Is there a requirement? So that's a whole other section, but let's talk about it for a second. Do you have to report them to the DMV? So what does it depend on? Your state. Your state and mine have different laws about this. There's an article in the Annals in the last couple of months which went over the reporting laws in all the different states, and they're dramatically different. And we talked a little bit about reporting laws with DV, but reporting laws are, on the one hand, they seem to be good public health measures. On the other hand, there's all these unintended consequences. So what's the unintended consequence of reporting somebody who has a seizure? What?
They can't get back and forth to the office.
They can't drive. So what happens? So they know you're going to report them when they have a seizure. Here I am. I have seizures. I'm on medicine. I'm doing okay. And now all of a sudden I start to have a few more seizures. But I need to drive. So do I come to you to fix my medicine? No, no way. I'm not going to do that because I'm going to lose my license. So I lose control because there's a terrible consequence of reporting. As it turns out, seizures, the incidence of traffic accidents in drivers who have seizures is about 1% higher than the general population. And the incidence, or a couple of percent, and the incidence of accidents which harm somebody is about 1% more. And the incidence of accidents, death, they're not different. Why is that? Because people who have seizures usually get an aura and they pull the car over. They have a little fender bender. So it's sort of bizarre that we live in a society where seizures you have to report. But we don't report the real problem. What's the real problem? Alcohol. Do you have to report when they come in they had an alcohol injury? No. In fact, you're not allowed to. So in some states, most states, the law doesn't read seizures. In most states, what it reads is if they have a condition characterized by lapses, plural, in consciousness. Seizures is a condition characterized by lapses in consciousness. So is drinking and driving. So I believe, while I'm not a big fan of reporting anything, unless you really need to, if we're going to report anything, we should report drunk drivers. And not only that, we should report drunks. Who cares if they're driving or not when you saw them? If they're a chronic alcoholic, every time they get in a car, they're going to be a danger to somebody. Maybe they shouldn't have a license. But do we do that? What would happen if I reported that to the DMV? They'd say, what are you talking about? They have no clue what to do with that. So, you know, it depends whether you're required to report it or not. But it's one of those things where I don't think the law makes a lot of sense. Let's go on. So hypoglycemia, the first thing is in these studies, they didn't notice any big problems, of course. There aren't big problems, but there'll be a few people who really need to be followed. Then what happens after you give them D50? Why is this a problem? Well, you give them D50, they're going to be okay for the next month. No. The next two, 5 and 6, are useful in that they say when you give somebody a standard dose of D50, the response is extraordinarily variable. Some of them raise their sugar a little tiny bit. Some raise it a whole lot. Some are back down below where you started in 30 minutes. And some stay up for as long as you can measure. So it's really important to know that if you're going to give D50, you know, when they leave, the guy had some insulin, didn't eat this morning, got a little hypoglycemic, you gave him some D50, he's better, you warn him, you better carry your, you know, don't let it get this bad again. And if they're in the hospital, depending upon the circumstances, you may want to just monitor them for a short period of time. But again, don't be surprised if you give D50 and you need to give a little more. Sometimes people need more than one. And sometimes it only lasts a little bit, and that's what these papers say. The next little bit is, what about sulfonylurea? And that's a real problem. And you know, there have been deaths associated with sulfonylurea-associated hypoglycemia because people didn't realize to keep the patient and continue to load them. And there are a couple, 7 and 8 are articles about octreotide, and they give dramatic examples of people who keep becoming hypoglycemic and hypoglycemia. You know, with sulfonylureas, with the long-acting ones, this can go on for days. Their half-life is 72 hours, 48 to 72 hours. So they need to be in the hospital, and they need to be monitored, et cetera. And these are dramatic case reports, case series, where they kept getting hypoglycemia, really impossible to manage. They gave them octreotide, and everything got better. And so actually it makes sense. The numbers in these papers is so small to know if it's real, but it sounds good, and it makes sense, because octreotide blocks insulin secretion, and sulfonylureas increase insulin sensitivity. So remember, in type 2 diabetics, they have some insulin, but they don't really respond to it very well. You give them sulfonylureas, they respond to it pretty well. You give them too much, they over-respond to it. Now you you cut off their insulin, and it makes sense that you stabilize the whole process. So I think it's probably right, even though the numbers, one is 9 patients, one is 1 patient. So, you know, but it's probably right. The next article, number 9, the introduction of it says, in a fascinating paper by Huizar, the only thing that's fascinating to me about this paper is that somebody published it. It's the most ridiculous paper. I'm not even going to talk about it. It's really silly. Number 10 is an important paper. It says that you need your kidneys to work to metabolize and excrete insulin. So when you have renal failure, guess what? You can become hypoglycemic. And it's a really nice case report. You know, somebody quoted me, Billy, I think, quoted me about case reports. I once wrote a little, you know, sort of tongue-in-cheek editorial about case reports, because I think for the most part they highlight all the wrong things. They highlight the extraordinarily unusual, and they get us thinking, oh, that's what the truth is, whereas it's not. It's only a case report because it's extraordinarily unusual. If you had a patient who got drunk and fell down, you couldn't write a case report. Nobody would publish it because it happens. We all know it happens. But if you had a patient who got drunk and played on Carnegie Hall, you could write a case report because it doesn't happen. So usually it's not true even. It's just an association that's probably even not true. But if it did happen, it's not what you should expect to see. On the other hand, case reports can sometimes highlight something that we haven't thought about, that is fairly rare, that's a new manifestation, and can lead us to learn something. And I think most case reports are not that, but sometimes they are. And this one was a case report of somebody who kept getting hypoglycemic, and they realized, you know, what started all of this? And then they realized, well, ooh, it was when we started her on an NSAID. And what do NSAIDs do? Well, they decrease renal function. And then they stopped the NSAID, her renal function, which her creatinine clearance had dropped, but her creatinine looked normal. It wasn't like she was in renal failure. She just wasn't as efficient as before. They stopped the NSAID. She stopped getting hypoglycemic. And so it does point out to us that anybody who goes into renal failure, diabetics, can need adjustment of their insulin. And you should be thinking of that. You see somebody who's all of a sudden, yeah, they got hypoglycemic and they come to you, but it wasn't once. They're starting to have these episodes. Think about maybe they're having decreased renal function. And then even, is there a precipitant of their decreased renal function that you could fix, like an NSAID? NSAIDs are great drugs. They're really safe. They're cheap. You know, most people can take them really well, but they have problems. And we give them to millions of patients. So guess what? There's thousands who are harmed. It's a great example of how even a really good drug, this is a relatively on the safety scale, a tremendous drug, can cause problems, can cause major, major problems. We'll talk more about that in the analgesia section tomorrow. So I think that's an important paper, number 10. If I were Stuart, I'd say circle that paper. Number 11 also points out that that when you are really anemic, you will overestimate the sugar. So you see somebody who looks hypoglycemic, you get a reading of 80, and you're saying, well, I guess it wasn't hypoglycemia. Give them the sugar anyway, because it may not be 80, it may be 50. And they may be hypoglycemic because for reasons that you can go over if you read the paper, you will overestimate your sugar when you have anemia. And renal failure patients, of course, have anemia. So you got the double whammy of they're more likely to have increased insulin effect because they're not clearing their insulin, plus you don't see it because the sugar looks like it's normal, and you can run into problems. The 12 and 13 are articles by Greg Hendy, one of my former residents who's now at UCSF Fresno. Terrific, terrific guy. And one of his little pet areas that he's been writing papers on for a long time is urine as a screen for ketones, as a screen for diabetes. And he points out that if you're looking for DKA, which I used to think was really important, why did it matter whether or not there was acidemia? Well, the reason I used to care was, I mean, the person who's sick, that's obvious. It doesn't, that's not a subtle clinical thing. But there were people who had a little high blood sugar, but if they were acidemic, we always admitted them because they were called DKA. Whereas if they weren't acidemic, you gave them some water and they cleared their sugar, you sent them home. And so it used to be really important, were they acidemic? The person who was really acidemic, that wasn't the question. You knew what the answer was. The person who was really sick. So it used to be, if you're acidemic, you don't go home. Nowadays, everybody says, no, mild DKA, you treat them, they do fine. As long as there's no precipitant that's obvious, that's dangerous, they can go home. Treat them just like they're a little hyperglycemic. So this question is a little less important nowadays. But Greg asked many years ago, well, do I have to do a blood gas? Maybe I could figure out if they're acidemic by just looking to see if they have ketones not in the blood, but in the urine. And his hypothesis, which these two papers show was correct, one he studied it, then he studied it prospectively and confirmed, was that you could be spilling ketones in the urine and not be acidemic, not be accumulating ketones in the blood. You know, what happens? You start to accumulate ketones, you start peeing them out. And as long as you're efficient at peeing them out, you don't start building up ketones and you don't develop acidemia. On the other hand, at some point, there's too many of them, you can't pee them out anymore, and now you become acidemic. So his hypothesis was, you can have false positive. If you have ketones in the urine, doesn't mean you have ketonemia. But if you have no ketones in the urine, and you have normal renal function, I mean, you're able to pee, you should be peeing out ketones before you start accumulating them. So if it's absolutely negative, you're probably not building up ketones in your blood. And these papers say that's true. If you have a negative urine for ketones, very unlikely that you have any ketones in your blood. Makes sense, and it's right. Again, I'm not sure it's terribly important. That it's the same is true for the next series of papers. True, but who cares in some sense. Why? The next papers, 14 to 18, are about venous blood gases. How good are venous blood gases compared to arterial blood gases? Great. The difference is trivial. It's, on average, it's almost unmeasurable, 0.01 in your pH, couple in your bicarb. They're the same. It doesn't even matter to remember which one is more or less, because they're basically the same. But then that raises the bigger question is, who cares anyway? So I'm not sure, you know, one of these articles says, how often does pH, a blood gas, change your management? And they came up with the conclusion, almost never. And I'm trying to think about it. Where's the almost? Because if the patient's sick, that's what I really need to know about. Now, you know, I'd like to know that they're very acidemic, but it's not going to change what I do. Basically, I'm going to treat them exactly the same. You don't give bicarb, you give them fluids, and you give them a little bit of insulin, and you make sure their K is good. That's what and you find the cause. So it's sort of interesting because, you know, when I first started, I started in internal medicine. I was really interested in pHs and blood gases and, you know, and all the equations that you use to figure out was it the mixed acid. And now I think, when was the last time I looked? Sort of like my stethoscope, you know. When was the last time I actually used it? Besides putting it in my pocket. I don't get MRSA because I don't actually put the stethoscope around my neck. You know, how often does it really matter? Of course, it does sometimes, and even blood gases do sometimes, but most of the time they don't matter, right? So, so there's a few articles that say they're not terribly important. Then in 19 and 20 make claims about how much insulin should you use, and they come up with this astonishing notion that a low dose was good. Well, yes, we know that. Low dose is not the dose isn't terribly important. And then there's one of these manufacturer studies saying our insulin was just as good. Well, of course, because insulin is not the treatment. The treatment is fluids. So it doesn't matter which insulin you use. The 21 through 23 are some of the many studies that say bicarb is not a good idea. None of these are randomized controlled trials. Nobody's going to do a randomized controlled trial, but I'm sure it's right. You don't need bicarb to treat acidosis. The only places where bicarb is important, as far as I can tell, are in those conditions where you want to artificially raise the pH above 7.4 in order to affect the body's handling of the toxic substance. And it's always, as far as I can tell, a toxic substance. So tricyclics, it's important to give bicarb. Aspirin, it's important to give bicarb. But those are the only places I can think where we should be using bicarb. Maybe to make your lidocaine a little less painful. But that you don't have to give to the patient. And then finally, the last series of articles come from this myth from the world of pediatrics that water is really bad in children. It's great in adults, but in children, oh my God, be careful. And here I'll only quote my friend Rick Bucata, who loves to say, it's really important to remember that children are merely little adults. Which makes our pediatrician friends tear their hair. But it's, you know, it's mostly true, right? For the most part, physiology is physiology, and for the most part, children respond in the same way as adults do. So where does this nuttiness come from? By the way, it's a huge amount of literature in kids that the treatment of almost all acute problems with kids is fluids. It's really, really important. Sepsis in kids, and even more than adults. I mean, they're so tenuous that you really have to get good aggressive fluids with them. And we know that that's the treatment of DKA, but somebody noticed a few years ago that the kids who got a lot of fluid, every once in a while, one of them got cerebral edema with DKA. And they said, oh, it must be the fluids, not thinking, well, maybe it's not the fluids, maybe they got a lot of fluids because they were really sick. So there's a really good paper in here by Glazer and Cooperman. I'll tell you which number it is in a second, but it's one of several that yeah, it's the last one, 29. Sometimes the last paper, I notice, is a good paper. 29 is a really well-done epidemiologic study which said the reason that that 1% of kids get cerebral edema, kids with DKA get cerebral edema, it has nothing to do with the amount of fluids you give them. It has everything to do with how sick they were when they arrived. And so the notion that you should be really careful. We just did a paper, same thing, which said, why are we giving kids half normal saline? You know, normal saline seems physiologic. If you're isoosmolar, you need normal saline. If you're hyperosmolar, the best treatment is normal saline. It gets you back down to normal in a nice, controlled way. If you're hypoosmolar, you need normal saline. It's the most physiologic treatment. So why for years have we been having half normal saline for kids? So they did a study and they said, you know what, normal saline's better. Kids are human beings, actually. Sometimes they don't seem that way, but they are. And you know, so this makes it really clear that the treatment of DKA in kids is the same as the treatment of DKA in adults. And I think this is particularly dangerous because the treatment is adequate fluids. And if for the wrong reasons you're afraid of giving fluids, and a couple of these articles point out these terrible emergency docs who gave too much fluids. There's one of these articles, one of my favorites, says, gave all these fluids to all these kids with DKA. Fortunately, none of them developed cerebral edema. And they didn't die either because you gave them the treatment. So I want to I'm done. I want to spend 1 minute just, there are a couple of comments in this chapter about diabetes that I think we really need to know the truth about. And they're not in any of the articles, but there is one overwhelming point about diabetes that needs to be made. And I think the chapter gets it a little wrong. So what is diabetes? So there are two types of diabetes. We all know that, right? And they're not exactly 100% different, but there's a lot of big fundamental ways in which they're different. Type 1, usually childhood, usually thin. They don't make insulin. They don't make any insulin at all. They need insulin. There's no other treatment. They're going to die otherwise. That's Banting and Best diabetes. That's the diabetes we all knew about. That's what used to be diabetes. Then along came type 2, which is insulin resistance. In our society, that is 90% of all diabetes nowadays. As we get bigger and exercise less and have bad lifestyles, type 2 diabetes becomes more and more dramatic. It's also true that there are certain ethnic populations where it's very, very, very rampant. American Indians, Hispanics, etc. So type 2 diabetes now dominates all the patients we see, even though it wasn't the dramatic disease. It's a very different disease. It is true you can get really sick with type 2 diabetes, and you can eventually get all the complications you get with type 1. But it's not nearly as fast, and it's not as dramatic a disease, much less likely to have DKA, for example, etc. Anyway, this is all as a prologue to saying what I think is the really important stuff. For many years, there was a controversy. Did it matter how well you controlled the sugar in diabetes? Does it matter if your sugar gets a little high or not? Now, you know when your sugar's high because you're peeing a lot, and you get thirsty and hungry. But if that's all it is, it's no big deal. So you want to treat the sugar, lower the sugar enough so that they don't have those symptoms. But does it matter in terms of the long-term consequences of diabetes? Do you have to be normal? Well, the problem with getting the tight control is that you're going to have, in order to do that, you have to take lots of insulin, and you're going to have episodes of hypoglycemia, which are potentially dangerous. So this was a big argument for a long period of time. Is the disease diabetes hyperglycemia, or is that just a marker of the disease, which is this complicated immunologic and vascular disease? That was a big argument. And along came the Diabetes Control and complications trial in 1992, I think, in the New England Journal. It was 3,000 patients with type 1 diabetes, and they showed that if you really got tight control and kept their hemoglobin A1C really good, under 7, they had better outcomes, real better outcomes. It wasn't a dramatic difference, it was a moderate difference, but it was real. Strokes, heart attacks, etc. The eyes findings, the only thing that didn't affect was the neurologic complications. But it seemed to be pretty good. Now, it came at a real big cost, 3 times the incidence of hypoglycemia, symptomatic hypoglycemia. And by the way, in order to be in that study, you had to be a really, really good patient, and you had to be a really good doctor. They screened the doctors and patients who was going to really comply, and they kicked out everybody else. And even with those, 3 times the episodes of hypoglycemia. So it wasn't a slam dunk, but most motivated patients would want to keep their sugar down. The same study, or a similar study, was done in type 2 diabetics, which is almost all the patients we see. And that was called the UKPDS study, United Kingdom something, PDS. I always forget what the name is. But UKPDS has been going on for 30 years. They've made over 100 papers from this so far. 33 and 34 were the key papers. I think those were the ones. They were published in The Lancet probably 10 years ago. And they showed exactly the opposite of the DCCT trial. There was no effect on any real outcomes. Now, this was despite the fact that the authors kept changing the goalposts and kept prolonging the trial and increasing the number of patients so they'd have more power to find trivial differences. And they tried and they tried and they tried and they tried and they tried, and they couldn't find any differences. They reported that there were differences. But if you look carefully, there were no differences. The only difference was the number of patients who got photocoagulation of their eyes. There was no difference in any other outcome. And photocoagulation of the eyes is a clinical decision which most people make based in part on what do the eyes look like and how bad is your sugar. So it probably didn't reflect any difference in disease. It just reflected they were a little more likely to do it because, oh, you got that disease and your sugar's not doing very well, we'll treat it. But there were no objective differences. There have been some really great critiques of UKPDS showing that they lied, cheated, and stole, that they tried every way to distort the results and even reported it as benefit when it's quite obvious there was no benefit. So there's a whole industry now about preventing diabetes, type 2 diabetes, and early treatment and all this, pre-diabetes, and they're selling millions of things for that industry. But the truth is we have no evidence that treatment of your blood sugar in type 2 diabetes, other than enough to keep you asymptomatic or less symptomatic, has any importance on all of the critical outcomes of diabetes. And I think it's important that we know about that before we get too zealous about you must take your diabetes pills and blah, blah, blah. The truth is that, as far as I can tell, there's enormous evidence now that this doesn't work. And so type 2 diabetes is symptomatic care seems to be the best. Oh, there is one other thing. In the UKPDS study, there was one drug that really affected outcomes, and that was metformin. And metformin affected outcomes no matter how good your diabetic control was. Even if your hemoglobin A1C got pretty high, if you were on metformin, you did better. And if your A1C was low and you weren't on metformin, you didn't. So metformin probably has some other effect that's important. But anyway, I thought it's something we should all know, because in here there are a few things about the importance of maintaining control in type 2 diabetes, and I don't think that's true. Go ahead.
Do you think there's a role for serum ketones in the evaluation or management?
Again, this is something where you're going to admit somebody who's got DKA, yeah, they're going to want to know, and they're going to think you're a bad doctor if you didn't. And you do want to know that they're not septic as well. This isn't lactic acidosis or some other thing. But for the most part, no, it almost will never really affect what you do. In a patient, you're going to admit you should do it.
So what do you think about just managing with sub-Q rather than IV insulin because of like half-life? I've been told, the half-life of IV insulin is so short.
So what about sub-Q versus IV? I think it's probably not that important. I like to have a drug that I can titrate as I go along, but since the insulin is not the primary drug anyway, it's sort of irrelevant. The key is, you need an IV anyway, so You know, it's sort of, it's not like you have to start an IV just to give the insulin. And, you know, it gives people something to do to follow the, you know. Okay, go ahead, one last one, and then we'll take a break.
Any special precautions for imaging for diabetics on metformin and things like that?
So imaging, just that, you know, we trash, I'm sure somewhere in this course somebody's made comments about the needless creatinines we get before we can do contrast CTs on patients and how stupid it is in the young, healthy person, et cetera. In diabetics, you know, everybody who gets contrast will have a transient decrease in renal function. If you have normal renal function, you have a small decrease, it doesn't affect you. If you have abnormal renal function, it can be bad. So I think these are patients where we should be, diabetics, we should be very careful about use of contrast. And if you can do an ultrasound instead or an MR or whatever, that's always better. Or a non-contrast CT. It's a good reason to say to whoever it is who's insisting on oral contrast that is unnecessary, well, in this case, yeah, sure, but in this case, you know, it's really risky, let's not do it.